Let us formally start this meeting by requesting Professor Jagatram, our worthy Director of PGIMER Chandigarh, to please welcome Professor Norman Sartorius. It's a tremendous day for us. I cannot say how joyed I am and we all are, but let Professor Jagatram do the honors by welcoming Professor Sartorius, please. Sir.
Good evening, dear Professor Norman Sartorius, the Chief Orator for the day, former HODs, Department of Psychiatry. We have with us Professor Savita Malhotra, Professor Kulhada, Professor Ajit Avasthi, Professor Mattu, and current HOD of the department, Professor Debashish Basu. So we have 5 HODs, 4 are former and 1 is current. Past, we have alumni of the Department of Psychiatry here and several guests and faculty members who have joined online. It is a matter of great pleasure and pride for all of us to be able to welcome Professor Norman Sartorius for the inaugural lecture in the Distinguished Speaker Series started by the Department of Psychiatry, PGIMER Chandigarh. The Department of Psychiatry at PGIMER Chandigarh was started by Professor N. Vig in September 1963. At that time, psychiatry was heavily stigmatized, mostly practiced in the confines of the mental hospital, and mental health was considered a very low priority. Dr. Vig helped to establish psychiatry as part of the general hospital in the community and was a pioneer of Indian psychiatry. He also emphasized psychiatric teaching and research. This tradition of excellence in teaching, research, and service continues till date. As an initiative to further enrich the academic of the department has started a distinguished speaker series. The speaker would consist of the eminent psychiatrists and other mental health professionals working in various parts of the country and world. They would share their experience and viewpoint and their knowledge and wisdom with the student and alumni of the department. This will benefit and motivate and inspire our students tremendously. We are very fortunate indeed to have a person of the stature of Professor Sartorius to deliver the first in the series lecture. He is a stalwart in psychiatry. I will just say a few words about him. Professor Norman Sartorius, MD, PhD, FRCP Psychiatry, was the founding director of the mental health program of the World Health Organization. He later became the president of the World Psychiatry Association and of the European Psychiatric Association. He now serves as president of the Association for the Improvement of the Mental Health Program, an NGO located in Geneva. Professor Sartorius holds several professional positions in Europe, USA, and elsewhere. He has published more than 500 papers in the peer-reviewed journal and authored and co-authored, edited or co-edited more than 120 books. His main areas of interest at present are the comorbidity of mental and physical disorders, the reduction of stigma of the mental disorder, and education of psychiatrists and other stakeholders in the field of mental health. In his previous position, he was the principal investigator of a number of international collaborative studies and projects dealing with schizophrenia and the other major mental disorders, comorbidity of mental and physical illness, health services development, and education of different categories of staff on behalf of Postgraduate Institute of Medical Education at Chandigarh. I welcome Professor N. Sartorius, and at this occasion I also congratulate Dr. Basu for organizing this excellent program. Thank you very much.
Thank you very much, Professor Jagatram, sir. Okay, permit me just to say a few more words before we start hearing from the stalwart himself. Actually, no words are sufficient, as we all know. And with the senior people, I can now see Professor Santosh Chaturvedi, I can see Dr. Vimal Sharma, of course, Dr. and all these people. But for the younger ones, because that is more important, we need to build up the new. So just a few words, Professor Sartorius, if you kindly permit me to say a few words about you, other than what has already been said, okay, about his WPA and the long stint with WHO, etc. Heavily decorated, what I would say, a soldier of psychiatry with a number of awards and honorary fellowship from literally from all parts of the world and from all professional, scholarly societies, including things like Lifetime Achievement Award from the Royal College of Psychiatrists, UK, and Asian Federation of Psychiatric Associations. This 85-year young and busy man has been hailed actually as psychiatrist's living legend in an article published on him, not by him, but on him in Lancet Psychiatry 2019. Other than his important works in psychiatric epidemiology and mental health policies across the world, which we are aware of, what is more important to us is that he has been a persistent advocate of anti-stigma campaigns to integrate psychiatry back to mainstream medicine. And more than being an astute academician, can you believe it that his H index, as per Google Scholar, I don't know if Professor Sartorius himself knows it, as of today stands as 109. I have not heard anybody other than probably with the exception of Kenneth Kendler. So 109. He loves talking to young students, early career psychiatrists and mental health professionals, motivating them, inspiring them, and challenging them to excel. Let me quote from a write-up written by his students and mentees from all over the world, again published in the Lancet Psychiatry last year. I quote, more than 3,000 young specialists have taken part in one of those programs which he runs called leadership programs. I think Abhishek from our department has taken part in that. More than 3,000 have taken part in around 200 courses in the past 20 years. Participants describe, I'm quoting, participants describe their experience as life-changing. So, and the last lines of that write-up, Sartorius's wisdom, openness, kindness, high standards of knowledge, truly humanistic values, creativity, honesty, and the great sense of humor are just a few of the attributes that have made him an outstanding mentor, inspiring teacher, and motivating leader. So, my dear friends, my young friends, do not look any further to flag off our distinguished speaker series, which Professor Jagatram spoke about with his lecture today. And interestingly, as he said, that Professor Sartorius has had a long-standing connection with India and PGIMER Chandigarh in particular, which he visited in the 1970s and 80s. I'm not sure exactly when, but in relation to international studies on schizophrenia. And he remembers fondly late Professor, our guru, Professor N.N. Vig, the founder of our department. I will end with this piece with a surprise photograph, courtesy Professor Savita Malhotra, my teacher, who had sent me. Actually, I had this, but I never, can you please, but I never, oh, share screen, yeah, which I never recognized earlier. So this is the time this one. Just one slide. Professor Sartorius in PGIMER Chandigarh, and there are at least 2 persons in this photograph who will recognize themselves. 46 years ago, sir, 1977. The handwriting you can see is of Professor N.N. Vig. The handwriting is written below. The Chandigarh, April 27th is written by Professor N.N. Vig himself. And you can, of course, Professor R. Srinivas Murthy has recognized himself, and Professor Savita Malhotra has recognized herself, I'm sure. But Professor Sartorius, can you recognize yourself?
Yes, yes, I can, yes. I should have taken the hands out of my pockets.
So here you are, 46 years ago, and there we go. We can see Professor S.K. and other people, Dr. Usha Naik, many other persons, but here we are to listen. And now I will just request Professor Jagatram to do a virtual inauguration. Right. So there you are. There is a photo, and here is the man himself. Can you stop sharing, please, Dr. Swapnajit, so that we may now request Professor Sartorius to start for what we have all been eagerly awaiting. Professor Norman Sartorius.
Thank you very much. It's a very emotional moment for me because, as you say, some of my early beginnings in psychiatry, particularly international psychiatry, have been linked to Chandigarh and to colleagues whom I met at the time over there. And I consider it really a great honor and a immense pleasure to be here and to start together with you this series. I should say I would also like to congratulate the Institute for having started this series. I think it is a use of which we previously didn't think about. Probably there were Zoom things in the past as well, but we never, it is the COVID which has forced us to stay put. But at the same time, perhaps stimulated also the notion that we should try to meet virtually if we cannot meet in other ways. So I think you are the first series of psychiatry in the whole of Asia that has started in this way. So I wish you all the best, and I really congratulate you for starting this. It is also a great pleasure to see some of the faces of people here whom I recognize and with whom I shared moments of joy, of despair, over things that went well or didn't go so very well. And it is lovely to also to think of a restarting of my regular visits to India by the courses which have been done under the supervision and under gentle hand of Dr. Santosh Chaturvedi, who has in the Bangalore Institute organized these annual events, which have now been interrupted because of COVID, but I do hope they will come back. It was wonderful to have both the contacts and to teach together with my Indian colleagues a number of outstandingly talented and brilliant young people. And I'm delighted that we have a perspective of having these courses in the future. And I hope that some of you at least will also be, I'll meet them there and maybe we can spend some time together. So with these words of congratulations, I would maybe speak on the topic that you have suggested that I should speak about, which is about the present state and the future of psychiatry. I have some slides which I would like to share with you.
Thank you.
So let me start by saying that that I think that we have managed to win a number of battles in the years since I first came to India in the 1960s. There have been at the time many considerably fewer of these events than some of those that I'll mention now. The United Nations has agreed to include mental health among its sustainable development goals. It's a major step forward. We have developed over the years and tested and are now quite confident about the use of a variety of treatment techniques, treatment technologies that in fact gives a chance to treat most of the people with mental illness with a very good chance of success. We have, I think, worldwide managed to awaken the consciousness of people about the terrible importance of stigma and the way in which stigma is stopping us from providing an appropriate life worth living to people who are mentally ill. But I think that the fact that we have recognized that it exists and that it has this power has been a major step forward. We have trained an enormous number of mental health professionals. There are now some 250,000 psychiatrists fully trained, and at least as many are in training, if not more, so that the number of highly trained professionals is becoming larger and larger. We have also seen that in a number of countries, the patient and family organizations have come into existence. And this was an important development, that people who had an experience of mental illness and their families are not only suffering in silence, but in fact that they are also have joined hands to see what they can do together. And very often they help each other in very major ways. The human rights of people with mental illness have been recognized. They've been recognized in an indirect way already by the time when the International Covenant on Human Rights was produced. But there's still a lot of work to be done, because the human rights have been recognized, and we have documents, the quality rights documents of WHO and many others. But here is a step forward that is undoubted. We have an enormous amount of new findings, and the research on mental health has been increased manifold in many countries with resources that have been put into it. And we have gradually been recognized that the promotion of mental health, that is in heightening the value which people give to mental health, has also been promoted, has been lifted on the scale of values. Very important. This is something that, in fact, is a major motivating force in doing it, anything in our field. We have some battles which we have to continue. These were the battles that we won, but some we have to continue. It is still, unfortunately, true that a large number of people with mental illness do not receive appropriate treatment. In European countries, with all the resources that currently exist, approximately 80 to 85% of the people with diseases such as schizophrenia are receiving treatment. But in the third world, in the countries of low and middle income, it is still 80% of these people do not have appropriate treatment. In fact, they have no treatment at all, and very often they perish where there is an opportunity and a possibility for them to live a life that is acceptable. We have the protection of human rights. Yes, it is true, but it's going slowly. It is in Indonesia. It was only a few years ago that they passed a law which prevented or which forbids the chaining of people with mental disorders. And I'm not mentioning other places in which it is the human rights are being harmed, although nobody speaks about it, and it's not very well seen. Stigma, yes, there have been now wonderful programs that have gone on in Britain, in Sweden, in Denmark, in Scandinavia, in Canada, in Australia, in New Zealand, a number of these programs. But when they happen, they are still separate programs. Fighting stigma is not a separate program. It should be a part of the treatment. It should be something that is inspiring the whole action of treatment and helping people with mental illness. And all of the society should participate in sharing this kind of a sense. And then looking at the treatment on one hand, and the training for this treatment on the other hand, in medical schools, treatment of mental disorders is the main topic for psychiatry. And yet there are many other things that we should be doing. And I shall speak about some of those in the future. So I think that is requiring a significant revision of the education for psychiatry, particularly psychiatrists, in the years that are before us. The laws on mental disorder and people with mental illness are unfortunately in many countries outdated, and in some other countries they are not outdated but not respected. And I think that in some countries these laws have only come into existence very recently. For example, in China, it is about 15 years ago, 10 years ago, that the first law on mental disorder and people with mental disorders have come into existence. In many of the African countries, particularly of the French language expression, they have still as their main legal basis the laws that have been passed in the 19th century, 1898, in France as their model. And of course that needs an upgrading and updating, which is very bad. I think that when I was saying that there is a lot of money that goes into mental health research, it is still incomparably too small because of the size of the problem and the public health importance that mental health disorders may have. And the people who unite themselves in these associations, while they are doing a wonderful job, they are very often dependent on one or two or three people who are carrying this on their shoulders and motivate them and bring everybody together and bring them to work together. And yet, when they are tired or when they get sick themselves, the associations very often flat on the ground. Alcohol and drug problems have found a new strength. They are growing in a major way again, in the form of huge epidemics of drug problems, like, for example, the fentanyl epidemic in the United States and in countries that have been having access to these synthetic opiates, but also in other countries, the drug abuse problems are huge. And what is so curious, the enthusiasm and the strengths of movement against alcohol and drugs have gone down. Somehow people consider it as with much less enthusiasm. There's much less engagement in thinking about ways to stopping drug abuse than there was in the past. And the promotion of mental health, which in my opinion is the single most important action that can be done, because we cannot expect that people will be doing things for mental health unless they value it very highly. And it's the high value that people give to mental health that will make them do things about it. And yet the promotion of mental health is given very little, if any, attention. Now, at the present moment, there is a variety of developments which are relevant to the future battles in the field of psychiatry and mental health. First is the phenomenon of commodification. Now, this is a complicated word. I think it didn't exist in the English language before. It was introduced by the World Bank at some 15 years ago. And it basically says that the current trend is to consider everything as a commodity. Health is a commodity like sugar or cotton or timber. You buy and you sell, and you pay for it and you get it. And the cheaper you can do it, the more you will profit. So that today you hear people who speak about the hospital being successful because it has a positive financial balance. It is everything is expressed in terms of money. And I think that, for example, the Lancet series on global mental health some years ago, the chief argument which was put forward in that series, which is otherwise wonderful, has been, you must do it because it's cheap. But it's not that you have to do it because it's cheap. You have to do it because it's an ethical imperative, not an economic opportunity. And I think that that notion that it is cheap, therefore should be done, must go out of our mind. It is not that we want to do things because they are good at the market, but because we are operating under the impulse of a feeling of ethical laws that should govern our behavior. Another phenomenon that has been very present is being also the digitalization of medicine. And this digitalization, where people are in fact communicating mainly by digital means, is wonderful in one respect, as for example, our series that we are now starting is, but on the other hand, it is being used where it's not necessary to use it. And it is being used without regard for the harm it may do, this digitalization, to human relations. And I think that the growth of reliance on digital means is to a large extent accompanied by a dehumanization of healthcare, of contacts between people. You're not talking to the banker any longer when you go to get some money. You are now talking to a machine, and the machine speaks to you. And everywhere else, you get this behavior which is sitting in front of a screen and not searching to find who these people are, what are they doing in their life, and so forth. Another phenomenon that has been of importance, particularly for psychiatry, has been the fragmentation of all professions. And medicine is among them. It's also being fragmented. The fragmentation has basically been happening because of a continuous emphasis on more and more specialities that should operate. These specialities, consequence of this specialization and super specialization, is that the person is no longer considered as a single human being who has a disease, but it's a composition of various parts, and various people have to participate in the treatment of such a disease in a single person. That has gone to such a level that in the United States, for example, they had to invent a new profession, the case managers, who go and accompany the sick person from one doctor to another and from one setting to another in order to provide care. They're sort of seeing a human being as a whole with a variety of good sides and bad sides and problems and diseases is significantly suffering because of this super specialization. Even in psychiatry, we started super specializing. We have a specialist for early interventions, a specialist for manic depressive illness, etc., which I think is something that we should overcome. We should try to see of ways in which we can see the totality, perhaps with deeper knowledge in one particular field, but not forgetting the total as a whole. Urbanization is another phenomenon that has happened. I just recently read that Jakarta is the second most populous city in the world, and I think New Delhi is not far behind it either. Huge urbanization with developments which are quite clear, and which on one hand bring some advantages like easier access to healthcare or whatever, but in fact have led to a significant weakening of interhuman relations, to an anonymity that people experience in cities, to a lack of existence of communities which we can call to help us in doing something about illness or about other miseries. Communities have vanished. We are still speaking about community mental health, but when we get in a town, we discover that most people don't know each other at all. They don't know who they are, they don't know their names, they don't care, and they don't want to know, which is even worse. The demographic characteristics of countries have also changed. I think a particular part is the change of the role of women, which has added a tremendous burden on women. In that they have been in countries of Western Europe and in other places, the women have in fact been saddled with another set of obligations, but nobody has been worrying about what should be done about the task which they were doing before, bringing up children, looking after the house, looking after people who are not well, being the main transmitters of culture. So they have to do these tasks as well as the new obligations, which present a tremendous burden. And I think that one should think really of ways in which one could help to carry this burden without destroying whatever functions they were previously done by them. And then there is a phenomenon which has been called horizontalization, which is an interesting phenomenon in that communication is becoming more and more horizontal. That is, people of the same age and same profession have more and more contacts, but the communication up and down becomes weaker and less intense. People speak to their equals, they're of equal age, they don't speak to their parents very much anymore. Their contact with their children is not very much. And even the children at different age range will have their horizontal links without having the vertical link, which brings together a feeling of community, a sense of belonging to a particular tribe or group or culture or whichever they might be. I think that there are some developments which are very useful as well. I think that particularly what has been seen in Australia and somewhere else has been the growth of the self-help movements and mutual help movements, something very positive. We shall have to learn ourselves very early in school how to deal with problems, for example. That would be problem-solving skills are not so difficult to learn, and yet there is practically no school, except when they are very inspired and talented teachers, which will teach children about ways of dealing with problems which they will encounter in their life. Mutual help movements is another one which has to be given appropriate governmental and local community support in order to operate properly, and it's very helpful. There are immense, there's an immense capital that exists in the mutual help field, which is at present not be recorded. I recall a particular event, a particular study that was done in, I think, in Guatemala, in which it has been demonstrated that when a pregnant woman is given another volunteer lady to be with her for the last 3 days or so, 4 days before childbirth, not being trained in any way, but just being there, helping a little bit, being also willing to listen, maybe talking about their own experience, etc. And the curious and the most important measurement that was done, women who had a companion for 3 days before their childbirth, the hours of childbirth have been reduced by 50%. It's been significant change in the physiological process that has been going because of the way in which the psyche was prepared for the event and the way in which we have been able. And there's numerous other examples of mutual help without terrible investment into training the helpers, which could be and should be done. Electronic information may be helpful also if you are far away or in other instances, and people can learn a great deal electronically, provided, as I said earlier, that it's used with a measure and with understanding. My hope is toujours with science, and I hope that science will discover ways in which we can deal with disorder, discover new treatments, discover new ways of prevention and so forth. So that is something that undoubtedly is going on as well. Well, as I told you, but we have new battles to fight. The one of the battles is this, which I mentioned several times, is the promotion of mental health in the sense of placing mental health higher on the scale of values. At present, patriotism has a certain scale value, various other things have various scale values, but mental health has to be lifted up from the very, very early childhood, building the scale of values on which people are. Another one of great importance, battles, is the primary prevention of mental disorders. Now, many people will tell you that in psychiatry, primary prevention is not possible. That is not true. There is a number of conditions, a number of states, a number of problems that are amenable to primary prevention. The most simple one would be to speak about things such as iodine supplementation, which can, if given to women of childbearing age, can reduce the number of children which are born with cretinism, How many? Several million children are born still unnecessarily with cretinism. We have good evidence now that not correcting mild sensory deficits, such as deficit of hypermetropia, for example, or deficit of hearing, will very likely enhance the probability of dropping out of school enormously. And the dropout from school is exposed to the dangers and the various other places that happen to children who are school dropouts, from disregard by their parents and scorning them, to getting into bad company, to starting to use drugs and so forth. Something that could be resolved very easily. We are saying we are doing it, but we are not doing it properly. There's been now several studies which have shown that school children who are given an eye examination have been found to be corrected for their myopia, but that most of the children with hypermetropia have not been discovered as being hypermetropic. And many of them have been sent to treatment for dyslexia because they cannot read properly. They cannot grasp what is going on paper in this respect, something that could be done better. Stunting of children. In various countries of low income, we now know that there are hundreds of millions of children who are stunted, and because of that, at high risk for a variety of diseases, including mental disorders. So I think that that's one area in which psychiatrists have to stop being psychiatrists and have to become advocates of measures, because the iodine supplementation is not done by psychiatrists, but it's the psychiatrist has to convince those who are doing it that it should be done. Another topic of major importance, the competent management of comorbidity of mental and physical illness. We know that people with mental illness die 15 years before people who do not have them. And most of them die from comorbid illness. And most of them, although they've been seen by their psychiatrists, have not been given appropriate treatment, not because, even in countries in which it is not a question of not having, but being a question of not being recognized and not being aware of the importance of dealing with comorbidity in an appropriate way. There is another area in which we unfortunately are not doing sufficiently, and that is what is being called the non-specific aspects of treatment. Some years ago, we published a booklet on that because we were at that time struck by the tremendous effect that non-specific aspects of treatment have. It has been said that if you have a medication, you give the medication, about 30% of the medication's effect is the real pharmacological effect. About 30% will be placebo. And 30% or so, 1/3, will be these non-specific aspects of treatment. Did you listen to the person when he came to speak to you about his problem? Did you treat that person with dignity? Did you give them a chance to think themselves and to express it? And so on and so on and so on. All that Frankl and others have been written about, but has not been taken. And I wrote down here the name of a little booklet, which is called the Rabbit Effect. And this rabbit effect was a story about New York, experiment that was done where rabbits have been given a very bad diet with a lot of fatty and substance and sugar substance and so forth, in order to see how quickly they will get heart disease and die from heart disease. And all of these rabbits did eat this food and were in fact getting very sick and died, except for a small group of rabbits. And when they found out, tried to find out what is it, why do those rabbits not die, they discovered that one of the lab technicians who was looking after them, he liked rabbits. And he spoke to them. And occasionally he stroked one of them. And occasionally he would clean their place a little bit. And the fact that he was having a different relation managed to prevent heart disease in rabbits. Now you can imagine what that kind of change of attitude and behavior of doctors, nurses, and others could do to people who have an incomparably larger diapason of feelings and who could be approached in many ways like that. Another thing that we should think about in new battle is to provide our colleagues in psychiatry with communication skills, because they need this. They have to have a skill of listening. They have the skill of convincing, of negotiation, leadership skills. We have started the courses which were mentioned earlier. I think because we felt that it was so important to try to develop these skills, leadership and professional skills. Unfortunately, in most of the postgraduate trainings worldwide, psychiatrists that go through become very good experts at recognizing disease, but not at recognizing people who are in front of them and handling their life with them in a manner that is effective and useful. And I think we shall have to revise the education about mental health and illness. We have to change the content so as to add knowledge and skills to people in there, so as to face these new tasks. We have to also change the place where the education is done. It is meaningless to speak about anxiety in an instance of cardiac failure on a Department of Psychiatry. That teaching has to be done in the Department of Cardiology, because there where the cardiologists sit and listen, and there is where they can, the students will learn that this is something that they can be done there with the skill that they get from psychiatry. We shall also have to think of who can teach. It's not us only who can teach. People who look after a mentally ill person 24 hours a day know much more about caring for people than we do. And it's important that we involve family members who have looking after somebody in our undergraduate and postgraduate teaching, not only so that they transmit knowledge, but also because it will help us to gain respect and really think of the tremendous role which they play and the life which they give in order to help others. And finally, we should have to think a little bit about changing the evaluation of candidates for psychiatry. When they enter, not everybody is made to be good in psychiatry. And it's very helpful, would be very helpful to such people to be advised early in their career that there are so many other fields in which they can excel. And perhaps in this particular one, they are not doing so very well. So altogether, I think I'm a cheerful optimist, I think, and I believe that the future of psychiatry and mental health is bright, and that we should, if we do sufficiently for it, we can improve the fate of people with mental illness, but also other people and the public health in general. And we can also increase the satisfaction of mental health workers about things which they are doing. And this doing for psychiatry and with people with mental illness may also help to return some of the soul to medicine, which is in a great danger to use it at present. Thank you very much for your attention.
Thank you so much, Professor Sartorius. We are overwhelmed. We cannot put it in words how very grateful to you are. We all are for this kind of what I would say as a panoramic scenario painting all over in a very short time, really. And every word I was telling my student Chandrima, whose device I'm using, I said that actually every sentence in this talk requires more of discussion because they are so heavily laden. But I guess rather than me speaking, I would like to hear now from some of the people we have very senior people, my teachers and my teacher-like figures who are all my teachers and who have known Dr. Sartorius earlier as well. So we'd like to hear from them, and we'd also like to hear a little bit from our younger ones. It's very important to hear a few maybe questions or comments from the students. We would not, because after all, it's for them. But let's start. It's an open house, so who'd like to say a few words or maybe ask a question or give short comments? Professor Srinivas Murthy, sir, please.
I remember reading about the importance of giving high value to mental health in one of his very early writings in the 70s and 80s. But I want to share with you two things which describe Norman Sartorius for what he is. I'm saying it because in 74, when I was doing my post-graduation, I did a seminar on classification of mental retardation because ICD-9 was coming. And in some bold way, I typed it myself and sent it by airmail to Dr. Sartorius because he had sent me some document. can you believe within a month or so, I got back hand-corrected thing so that it ultimately got it published in the Indian Journal of Mental Retardation. This commitment to support young people is the signature of Dr. Norman Sartorius. Second, the memory I want to share was during the World Health Report 2001, 20 years back when I was in Geneva for 2 years, he was a constant support. No, not only to just guide, but to morally support. And I think this, the point which he made about human relationships, he puts it into practice in every minute of the day. Thank you very much, Norman. And the point that you have made about promotion of mental health and sharing of skills, involvement of caregivers is very close to my heart. And I'm very glad that you brought these things to the thing. Thank you for joining us. We miss Dr. Vic, who was such a dear friend to you. You know, first time when you came in 73 to Chandigarh, the Tribune called him Norman Sartorius because they didn't know what is Norman. So they called him Norman Sartorius. I still have the paper cutting with me in my files. Thank you very much.
Thank you. Thank you very much, sir. Dr. Sartorius, would you like to briefly respond, or would you like to respond towards the end? It's your way.
Well, I mean, I would like to say something later, of course, if you give me a chance. But I want to thank Srinivas for bringing the human aspects, which really marks in many ways, particularly my time in India. And so it's a wonderful thing to remember and to hear some of this. The fact that I was called normal was a great source of encouragement for me. My primary target for intervention is ourselves. We should become a little different from what we have been in the past. We should be kind to people, and we should be also aware of the role that we are playing, and we should, by example, infect other people in a manner of behavior which will make us respected. And I think that that aspect, that we are not only carriers of knowledge, we are also being watched with our students to see what we are like, to see what we are doing, whether we are paying attention to anybody, whether we are cordial, whether we are right for psychiatry or not, is tremendously important. And I think that first object of work would be ourselves. Let us ourselves become a little bit different from what we are. We are not laboratory technicians. We are people who are central to the medical treatment and to human treatment of people who are in misery. Now, once we achieve that, which will mean that we have to learn some skills, but we also have to learn to know ourselves sufficiently to know whether we can get there or better go and do something else, because it's not possible for everybody to do it. And once we have done that, we can then proceed. And there you can say, all right, now, which groups deserves most attention? Primary prevention undoubtedly is very important. Children would be very important. But it is the radiation, if you wish, of our way of seeing people, which would be terribly important. And that should inspire our students. Our students should be inspired by us, not only learn from us.
In the chat box, one of our young students who is pursuing DM in child and adolescent psychiatry, Dr. Vail Prasant, has put up a question, which I don't know if Dr. Sartorius can see it from there, but in any case, I'll read it out. I'll read it out for you. Simple question, but a very good question. In this era of ever-growing neurobiological understandings of disorders, will quote-unquote phenomenology and descriptive psychopathology hold its value in future? What do you say, sir?
I have to ask this question of the person who has asked the question. Will he keep it? Will he, in fact, see that this is more important? Because he's one of many. And I think answering that question for himself, what are all the attraction that neurobiology, etc., has, and what are the shortcomings of that? And when I spoke about the fact that not everybody can become a psychiatrist, one of the aspects of it is, if you are really terribly attracted by the laboratory, it is a certain way of living which is not compatible with good psychiatry. Psychiatry requires other interests in life, other ways of seeing the world, other ways of seeing people, than sitting behind a computer and trying to play some computer games. Both are very helpful, very useful. I think neurobiology is wonderful, but I think that we will have to strengthen the other side, which will try to understand, because phenomenology and descriptive psychopathology both depend on seeing the person in front of you, not as a piece of wood, but as a person who has who is interesting, who has thoughts, who can tell you things, from whom you can learn, whom you can teach. I mean, this is a exercise in human relation. And I think that the young colleague who has asked that question asks a very serious question. How can we help young colleagues not to drop phenomenology and psychopathology? The Americans, unfortunately, had a strong influence in this respect. And I think out of the 180 medical schools in the United States, there is none, or at the time, at least when we looked at it, none that has been having a professor of psychopathology. They were all doing other things, but psychopathology as a discipline of importance of learning the behavior and reading and correcting, etc., has not been taught in that. And since many of the people went to the States, I think the influence of biology and laboratory, etc., has been excessively strong. It's useful, but it should not be the only one.
Thank you. Thank you very much, Professor Sartorius. I think Dr. Chandrima, who is our student and a senior resident, and whose name I have kind of observed for the time being, has a
yes.
question. Go ahead.
Hello, sir. It was really nice listening to you. One thing, like I have always been fascinated by psychiatry. One thing which brings a lot of kind of a stigma from the other medical colleagues who are non-psychiatrists is something like your diseases, your diagnoses are not even like valid. Like you keep on changing your diseases, new diseases keep coming up, old diseases keep getting like dropped out, saying these are not diseases. So this nosology thing, which keeps on changing very frequently. So what do we expect in the future of psychiatry in the nosology of our disorders?
Well, your colleagues in internal medicine, for example, will undoubtedly be aware that the International Classification of Diseases, which has a chapter that deals with various other diseases, is changing just as much as psychiatry. But psychiatrists are making more noise about it, so that they speak about the ICD-11 and 12 and 14 and whatever, DSM-5 and 4, etc. And I think that we have been, of course, handicapped by the fact that most of our diagnostics relies on the examination of the person and the symptoms rather than the laboratory findings, which are still a little bit background. But I think that gradually the classification, if you look at the way in which psychiatrists are being excited about the classification, say 20 years ago and today, there's no comparison. At present, the ICD-11 has sort of gone through and the DSM-5 has been accepted, but there hasn't been the excitement about this new classification, etc., at all. And I think gradually there has been a coming to senses, understanding that there are limits to the refinement with which we can approach nosology, and that we should be very careful about changing it. There are attempts to do things more drastically, like the American, rather the NIMH attempt to have some other ways of classifying mental disorders, etc. But I think that altogether the excitement about nosology, classification, etc. is gone down, and that we shall live for the next, I would say, 40, 50 years with the same classification as we have it now. Even if we discover what these diseases are all about, classification is not likely to change very much.
Thank you. Thank you. Thank you so much. We have kind of run out of time, really, but there are two questions one from Dr. Babita. Both are very profound questions. I wonder if you can take them and can answer them at this time. One is called Impact of Globalization on the Future of Psychiatry. Extremely profound question, of course. And from a very young person, Babita is from Nepal, and she's doing her residency here. So that's her question. And the second one is from Devendra, who asks that how psychiatry will fight with forces of capitalism that enhance
Sorry, it's forces of
capitalism,
capitalism.
which enhances commodification. I think your word commodification has really kind of struck a chord because it's something very important. If these two questions can be taken up by you, sir, we'll be very grateful, because after that probably we'll have to, we could go on for another 1 hour, I'm sure, but then we'll close after that. But these two questions, please.
Well, globalization, when it was first invented as a name, we were all very pleased with it, because we thought that here will be an opening of borders and people will freely exchange ideas, and there will be a equality in transposing goods and values, etc. As it turned out, globalization has lost some of its charm, and many people see it as a different form of colonialism, because it is not done properly. It is not that people have opened border and said, all right, now let's go both ways. No, it has in fact been a new name to some of the old sins. So globalization is not, has not given us what it has promised when it was first invented, global mental health and global things. So I think that it will gradually, it will vanish, it will go away again. It is not, it will not, it has lost its, I would almost say, religious appeal, and it's now becoming a phenomenon that borders are opened or closed depending on political and other economic ideas and so forth. So I think that globalization has not been helpful until now in many ways. It's been helpful for some people who used it to do good things, but most of the globalization has underperformed in terms of promises that it made in the beginning. Whether it will influence psychiatry more, well, I think that the digitalization is influencing it more. In fact, being able to be in contact with people worldwide much more easily and much more frequently is much more impact on the things then. But for the moment, I think that we will have to work a little bit more before we get to what one would call just globalization, in which justice will be and equity will be included, and not only what is currently going on. Whether I think capitalism, well, capitalism to a large extent is what is behind commodification, and it is a accumulation of money and value into a very small number of hands, which makes it very difficult to make progress because the power lies in so few hands. I don't think that there was anybody ever, I mean, the fact that somebody like Mr. Bezos has $160 billion at his call is an extraordinary development, which of course makes any social progress very difficult. There must be more equity in the distribution of resources, and it's very difficult. I'm worried about the accumulation of capital in very few hands, and I'm not quite sure what one could do to really all the what would call it attempts so far to break it down has been only partially successful. The system of trying to control it by a taxing system works, yes, but not completely, and so forth. So it is a big problem. I hope that this accumulation of capital and the power of capital will find a solution in the near future, because otherwise it will cost us too much. It's really a danger that is before us.
Thank you. Thank you. Thank you so much, Professor Sartorius. We wish we could go on for another 1 hour or whatever, because we are still getting questions, but we'll have to put a end to it, at least for now. But extremely thankful to you, certainly, but also to the whole group, to everybody who was there. I would like our worthy director, Professor Jagat Ramji, to say a word of thanks on everybody's behalf. And we can't pay you. We can't do anything for you. Okay, you are far too. But it's just our heartfelt gratitude that we can with. Sir, Director PGI,
Yeah.
please, for words at the end.
Sure. It was a great pleasure to listen to outstanding and inspirational lecture from Professor Norman Sartorius. Thank you very much, sir. It was truly great, sir.
Thank you. Thank you very much for listening to me and for giving me this opportunity to see many of my colleagues and friends from other times. So for once, the Zoom has been a very useful tool to see faces and to be in touch, even if it's only a virtual touch. But I do hope that all of this COVID will abate a bit. My heart is also with India, which has suffered so badly during that period. And I hope that we can get rid of that and then meet again alive and well and think about things together.
Yeah, thank you. We just have a last kind of, again, a virtual certificate of appreciation, which I request Dr. Swapnaji to do the needful. Everything is virtual. So, okay, there you are. It's a beautiful photograph, by the way. Right. So that's just our heartfelt gratitude to Professor Norman Sartorius for addressing our departmental members and alumni on the topic, the present state and future of psychiatry, as the inaugural lecture of the Distinguished Speaker Series on 25th August 2021. And that's all we can say, sir. You have flagged it off, and now we would like to have more people to inspire, motivate, and make us more wise for everyone. Thank you so much.
Thank you very much. Thank you.